This 3D rendering maps the global distribution of oral cavity squamous cell carcinoma. Worldwide, the thermal hotspot sits directly on the lateral border of the tongue. But in India, the highest incidence shifts to the buccal mucosa and the gingivo-buccal sulcus. This animation illustrates the underlying pathogenesis. Carcinogenesis in the oral mucosa is a multi-step process, heavily driven by p53 mutations. A uniform layer of cells undergoes dysplasia, progresses to carcinoma in situ, and finally breaches the lower mucosal boundary as invasive carcinoma. Looking at this stylized histological slide, we can distinguish the grade of the tumor. Well-differentiated squamous cell carcinomas present with distinct concentric keratin pearls and visible intercellular bridges. Poorly differentiated tumors grow aggressively without these obvious signs of keratinization. The primary etiologic matrix driving these cellular mutations relies on synergistic risks. Smoked tobacco, smoke-less tobacco, heavy alcohol consumption, and the chewing of areca nut and betel quid directly expose the mucosa to potent carcinogens. Secondary factors accelerate this decay. Constant mechanical trauma from ill-fitting dentures or sharp teeth exacerbates the damage in an already exposed field. Immunosuppressed patients face higher risks, while viral drivers like HPV strongly correlate with oropharyngeal cancers, though HPV-positive tumors generally carry a more favorable prognosis. These chemical, mechanical, and viral factors saturate the entire mucosal environment. They corrupt the regional tissue architecture, setting a continuous oncological trap rather than causing a single isolated tumor. This animated timeline and mucosal map illustrate a concept known as field cancerization. When an entire mucosal field is bathed in carcinogens over time, it generates multiple, independent, and multifocal premalignant or malignant lesions. Notice how the timeline groups these emerging lesions. If multiple tumors arise within 6 months of one another, they are classified as synchronous cancers. If a secondary node appears after that 6-month window, it is a metachronous cancer, a completely new primary tumor, not a metastasis. Clinicians monitor this exposed field for specific premalignant warning signs. Leukoplakia is a white plaque that cannot be clinically wiped off. Its malignant potential spikes if the lesion is non-homogeneous, large, multifocal, located on the lateral tongue, or if it presents in female non-smokers. Erythroplakia presents as a red, velvety patch that also resists being wiped away. This lesion carries a substantially higher risk of harboring severe dysplasia or outright carcinoma compared to leukoplakia. Both of these must be carefully distinguished from hyperplastic candidiasis. A candidal infection may look like a white plaque, but it can often be partially scraped away to reveal an erythematous space. In populations exposed to betel quid, patients may develop oral submucous fibrosis. This hypersensitivity disorder creates tight fibrotic bands that severely restrict mouth opening. Management requires immediate cessation of the carcinogen, intralesional triamcinolone, and physiotherapy. Indiscriminate surgical release of these bands often worsens fibrosis. Systemic conditions also elevate risk. Plummer-Vinson syndrome typically affects perimenopausal women, presenting with a triad of iron deficiency anemia, spoon-shaped nails called koilonychia, and post-cricoid webs. This specific syndrome significantly increases the risk of hypopharyngeal and esophageal squamous cell carcinoma. Recognizing the specific visual and structural properties of these premalignant lesions determines whether a patient receives preventative medical management or requires immediate surgical extirpation. The diagnostic standard for these lesions is an incisional biopsy. The sample must be taken from the active edge or as a representative wedge of the tumor. Surgeons actively avoid the necrotic center, which is often composed of dead tissue and yields a non-diagnostic result. If the biopsy field is heavily infected or inflamed, the resulting tissue architecture will be obscured. The clinical protocol requires treating and resolving the local infection first, then repeating the biopsy to secure a clean sample. Sometimes the primary lesion remains hidden. A patient may present with an enlarged cervical lymph node that confirms metastatic squamous cell carcinoma via fine needle aspiration, yet a thorough clinical exam reveals no obvious tumor in the mouth or throat. This is an unknown primary. To locate an unknown primary, clinicians rely on PET-CT imaging and direct targeted evaluations. They inspect highly suspect occult sites where tumors easily hide: the retromolar trigone, the base of the tongue, the tonsillar fossa, the fossa of Rosenmuller, and the piriform sinus. Once the tissue diagnosis is secured and the occult sites are cleared, the investigative phase ends. The clinician then applies a strict mathematical rigor to stage the tumor. AJCC 8th edition staging relies on depth of invasion. Tumor thickness measures vertical height. DOI measures strictly from the basement membrane down. Tumors under 2 centimeters with a DOI under 5 millimeters are T1. Greater sizes or deeper invasions escalate the stage to T2 or T3. While T staging measures the primary site, the N category, representing regional lymph node metastasis, is the single most important prognostic factor. Within N staging, extranodal extension serves as a severe clinical modifier. Witness the mechanics of extranodal extension. Metastatic cells physically break through the fibrous capsule of the lymph node, expanding outward and adhering to surrounding structures. Clinically, this manifests as a node that is hard, matted, or fixed to the overlying skin. When a node is stuck to surrounding tissue, it immediately upgrades the nodal stage to N3B, regardless of the node's actual size. Let's apply this calculus to a real scenario. A lateral tongue lesion measuring 3 by 2 centimeters is a T2. A 4 centimeter hard node fixed to the skin triggers N3B. With no distant metastasis, the final staging locks in at T2 N3B M0. These millimeter measurements and nodal characteristics dictate the required response. They trigger precise, aggressive surgical algorithms designed to clear the disease. The primary goal of extirpation is an R0 resection, achieving completely clear surgical margins. To guarantee success, surgeons typically excise the tumor with a strict half-centimeter perimeter of healthy, normal tissue on all sides. Gaining access to the tumor depends entirely on its location. The visor approach provides exposure to the anterior mandible and floor of the mouth. The lip split approach opens access to the lateral mandible and buccal mucosa, while the Weber-Ferguson incision exposes the maxilla. Advanced disease often requires a composite en-bloc resection, known as the commandos procedure. This aggressive protocol combines a wide local excision of the tumor, segmental resection of the involved mandible, and a comprehensive neck dissection simultaneously. Lip cancer relies on a defect-driven algorithm. Defects involving less than 1/3 of the lip are closed primarily. If the defect spans 1/3 to 2/3, surgeons use the Johansson stepladder technique to prevent microstomia, a severe narrowing of the mouth. Defects larger than 2/3 require complex flap reconstruction, such as the Abby Eslander flap. Location also dictates lymphatic surveillance. Tumors positioned at the angle of the mouth, crossing the midline of the lip, at the tip of the tongue, or on the soft palate, exhibit high rates of contralateral lymphatic drainage, mandating bilateral neck evaluation. Surgeons must also differentiate malignant tumors from incidental odontogenic lesions that mimic bony involvement. Dentigerous cysts associate with unerupted teeth and require simple enucleation. Dental cysts stem from infected teeth and resolve when the tooth is removed. Ameloblastomas, however, present as bony, hard mandibular swellings and require wide local excision. Securing negative oncologic margins frequently requires excising critical bone, muscle, and vascular tissue. At this point, the operation shifts from extirpation to complex regional control. This schematic maps cervical lymph node compartments. Standard neck dissections focus on levels 1 through 5 laterally. Level 6 represents the central compartment, housing the Delphian node. A radical neck dissection clears levels 1 through 5, while intentionally sacrificing the sternocleidomastoid muscle, internal jugular vein, and spinal accessory nerve. Modified radical neck dissections still clear levels 1 through 5, but spare at least one of those 3 non-lymphatic structures. Functional neck dissections clear the nodal disease while successfully preserving the muscle, the vein, and the nerve. Selective neck dissections clear only specific high-risk nodal basins. For example, a supraomohyoid dissection targets only levels 1 through 3. Surgeons frequently utilize this prophylactically in clinically node-negative T1 and T2 tumors to significantly improve disease-free survival. Operating in this dense anatomical corridor carries severe hazards. A postoperative infection can lead to common carotid blowout, causing fatal hemorrhage. Injury to the spinal accessory nerve results in chronic shoulder pain, shoulder droop, and weakness in arm elevation. The marginal mandibular nerve is also highly vulnerable. To prevent permanent drooping at the angle of the mouth, the surgeon must place the neck incision at least 2 finger breadths below the lower border of the mandible. Ultimately, exacting anatomical precision allows the expert surgical team to clear regional metastases while completely avoiding devastating functional deficits. Once the cancer is removed, reconstruction follows 3 strict mandates: restoring structural facial contour, ensuring functional swallowing, and maintaining oral competence. Look at the top left quadrant of this matrix. For massive soft tissue defects in the head and neck, the pectoralis major myocutaneous, or PMMC flap, serves as the reliable regional workhorse, utilizing a vascular tether from the chest to the neck. Moving to the top right, the free fibular flap is the absolute gold standard for reconstructing bony defects. It is exceptionally useful for rebuilding an edentulous mandible, relying entirely on the perineal vessels for its blood supply. In the bottom left, the radial artery forearm flap offers the most versatile free flap option for intricate soft tissue reconstruction. Because it harvests major vascular tissue, it strictly requires a preoperative Allen's test to guarantee the hand will retain adequate collateral blood flow. Other specific defects call for alternative flaps. The deltopectoral flap provides another regional option, while the Abbey-Estlander flap, based on labial vessels, is specifically designed to restore the angle of the mouth. Reconstructive success requires matching the specific vascular, bony, and soft tissue properties of the donor site to the precise geometric void left by the tumor. Surgery rarely acts as a standalone cure for advanced disease. Postoperative chemoradiation is aggressively deployed when pathology reveals high-risk features, including extranodal extension, perineural invasion, lymphovascular invasion, or exceedingly close surgical margins. When a tumor is borderline or outright unresectable upon presentation, clinicians use neoadjuvant therapy. Administering chemotherapy and radiation before surgery shrinks and downstages the primary mass, converting an inoperable patient into a surgical candidate. If the squamous cell carcinoma becomes recurrent or widely metastatic, clinicians transition to systemic immunotherapy, employing PD-L1 inhibitors to activate the patient's own immune response against the spread. The full continuum of oral oncology relies on an array of systemic therapies and microvascular flaps to rebuild the patient. Yet the entire prognostic calculus ultimately hinges on those initial microscopic thresholds: the absolute depth of the primary invasion and the structural integrity of the cervical lymph nodes.